All right, I am excited to introduce Dr. Riccardo Superina at Lurie Children's Hospital in Chicago, Illinois. Dr. Superina is head of the transplant surgery at Lurie Children's Hospital. He's joining us today on our Instagram Live Q&A to help others on their journey to learn more about living with an Abernethy malformation. And our first question is, why did you become a surgeon?
Hi. Thanks for having me here. I'm going to be sipping coffee every now and then because I've been up all night, so I hope that's okay. So, as many things in life, becoming a surgeon was a little bit of an accident. I went into surgery because I didn't think I could do internal medicine because that seemed to be mostly just making rounds all day long. and not really taking part in actual patient care except from a distance. Whereas surgery, you were able to see the results of your work firsthand. And I didn't think I could ever make it into surgery because it was very competitive. And then going into pediatric surgery was even more competitive. But somehow I made it through all of the barriers, and then I, just here I am. It was kind of almost like fate. There was no grand plan from the time I was 5 years old or anything like that.
Well, we already have 3 people online. I already see from Jen. She's saying hi to our favorite doctor. So you've already got watchers. This is
Nice.
Good. Second question. What is an Abernethy malformation?
So it's a little complicated. The real term for an Abernethy malformation is a congenital portosystemic shunt. That is sort of the more official term. John Abernethy was a surgeon that lived in England in the late 1700s, and he was quite an interesting character. He did a lot of, he was actually very well known for something called the Abernethy cookie when he was alive. And I think he invented this cookie in order for something to be both nutritious and help with digestion. Or it wasn't an Abernethy cookie, it was an Abernethy biscuit. And so he discovered, really in autopsy specimens, the malformation which now bears his name, which was, it's really the veins of the intestine normally drain into the liver through the portal vein. And that's just an invariable feature of human anatomy. But he discovered this rare condition when by the portal vein, instead of going into the liver, went around the liver or went outside of the liver and went into the veins of the general veins of the body and back to the heart without going to the liver. And since his time, we've discovered other forms of the Abernethy malformation, but strictly speaking, we tend to call everything now the Abernethy malformation, any condition in which the anatomy of the portal vein drains outside of the liver back to the heart. But very specifically, his was a condition where the portal vein dumped into the inferior vena cava behind the liver. And that's a very common malformation. But now we generalize and call almost everything the Abernethy malformation, except for people who are true purists, and would call everything else a congenital portosystemic shunt.
What tests will be involved in diagnosing an Abernethy malformation?
Now ultrasound is the commonest way these malformations are discovered. Often they are discovered by an ultrasound being done for something else. So the portal vein is usually extremely easily seen on an ultrasound, and a skilled ultrasonographer may be looking for a kidney stone or maybe looking for a heart defect, and then they'll see this very unusual situation where the vein from the intestines does not go into the liver. So it's quite easily seen on an ultrasound. in most cases. There are other forms of the Abernethy malformation, as I said before, in which the vein joins up in the pelvis or it joins up into the chest, and those might be more difficult to diagnose with ultrasound.
So for those, would you do more of like a CT scan or an MR or something like that?
Yes, CT scan or an MR are the most common.
And are there any significant risks for any of the testing that you do?
Not really, no. CT scans are, patients are nervous about having their children exposed to radiation, but it's a very small amount of radiation. So, it's like the radiation you would get if you walked into the ER with abdominal pain. You got a CT scan for appendicitis. That happens every day, all day long, and so it's the same. An MR is no radiation whatsoever, so it's pretty safe.
Good. How many cases have you treated so far?
As I said, it's a good question. The number is not going to appear gigantic. It's not like thousands of cases because it's a very rare malformation. So in our center here in Chicago, I have seen, I would say, somewhere between 70 to 100 cases. And that includes patients that have not had an operation or in whom the shunt has closed spontaneously. Of the patients that we've actually operated on, that number is closer to 70. So when you think about, how many people have gallbladder disease, or millions, if not billions of people, this is a very rare malformation. So when we see, we've become a sort of a referral center for other places, and so we get to see, I think, far more than anybody else. So,
what causes an Abernethy malformation?
Well, it's the cause of the Abernethy malformation, I think, is just the way the baby forms in utero. It's like some children are born with club foot, some children are born with a congenital heart disease. It's a developmental defect. The exact nature of it is not known. Why people are born with it. I can say that it does occur in conjunction with other congenital defects very commonly. So associated heart diseases probably happens in about 25% of people. So I think it's a disorder of cardiovascular system formation.
What are some of the possible negative long-term effects of having an Abernethy malformation if it's not treated?
Yeah, another great question. I'm gonna take a sip of coffee before I answer that one.
Go right ahead.
Well, I think Abernethy himself and others since have thought that the Abernethy malformation is simply an anatomical curiosity that doesn't really need to be treated. But we know that to be very different nowadays. It's a kind of a sneaky type of disorder because it doesn't present with abdominal pain or headache or something that will send you to the emergency room. As I said, many patients have this disorder discovered almost accidentally while they're being investigated for something else. I can't remember the exact circumstances of Manny's diagnosis.
Yeah, failure to thrive.
Yeah. So it's very different. But we do know that the long-term effects of this blood being basically unfiltered by the liver can lead to many, many different kinds of problems. First of all, the liver itself doesn't grow normally because the portal vein normally brings a lot of nutrients to the liver from the gut. And there's a sort of a symbiotic relationship between the gut and the liver. So the portal vein brings nutrients. Without them, the liver regenerates in a very awkward and inefficient manner. So some patients get liver masses, liver tumors. I would think about 30 to 40% of our patients have tumors that can, in the long term, become malignant. So that's a big deal. Pulmonary problems are huge. Long-term effects of this unfiltered blood leads to pulmonary hypertension, so high blood pressure in the lungs, and that can lead to heart strain over many years and cause heart failure. It can cause the hepatopulmonary syndrome, whereby the blood that goes to the lung isn't exposed to oxygen properly, so patients need chronic oxygen therapy, and eventually they can't breathe properly. And so these are kind of examples that are probably the commonest, though, is encephalopathy, where the ammonia and other neurotransmitters that are normally taken out of the circulation immediately by the liver circulate and impair one's ability to think clearly, or to process information properly, or to read a book, because your attention wanders or interferes with your sleep. This kind of stuff. Failure to thrive. People don't grow normally. So these are all very sort of, and if you go to the doctor and you're like, oh, I'm just tired all the time, my child's not growing properly, the first thing that pops into your head is not an Abernethy malformation. So it's a diagnosis that leads to many kinds of symptoms. And one of the articles that we want to write eventually, we should have written it long ago, is kind of in general terms, it's called like the Abernethy syndrome, the great masquerader, or something like that, whereby I think a lot of physicians aren't even aware of what it is, or what the long-term consequences are, or that something can actually be done about it.
Definitely. What are some of the different types or classifications of an Abernethy malformation?
There's been a few. Glenn Morgan, who's a colleague of mine back in the 90s, came up with a very simple classification, like a 1A, 1B, and 2. And a lot of people still write about that. And it was really just kind of based on, so the Abernethy malformation is essentially, some people call it the congenital absence of the portal vein. So like you have the shunt and nothing going to the liver. Well, the reality of the fact is that there are little branches that do go to the liver. And we, back in 1994, whenever we wrote this article, we didn't have CT scans or MR scans as good as they are now. So we did have CT scans. And so the first few patients that I saw either had a portal vein, a little one, or did not. So we said, oh, okay, so class 1 will be the ones without the portal vein, and class 2 will be the ones with a small portal vein. But we know now, in the light of the more sophisticated testing we have today, that there are very few class 1s, because now we know that almost every patient that comes along with an Abernethy malformation has a small portal vein that can be demonstrated by very specialized radiological techniques. I'm sure there are true type 1s, but I think that we can almost always grow a little portal vein despite the apparent absence. So I think it still serves a purpose in terms of saying, okay, well, the class 1s are either no portal vein or very small, and the class 2s are the ones with the more obvious portal vein. The French have done a lot of research in this area, and they've come up with their own complex classification. We were just at a conference, the first international conference on the Abernethy malformation in Paris in March of this year, where we got together with our French colleagues and really had a symposium on this thing. And it was not very well attended. I mean, relatively speaking, there were about 100 people, and they're all physicians from all over the world. But we talked a lot about the kinds. Another common classification is the ones that are inside the liver and the ones that are outside the liver, so intrahepatic and extrahepatic, with the intrahepatic ones being more amenable to radiological cure or treatment, whereas the extrahepatic ones tend to be more surgically treated.
We just had a question that came in from Cindy. How can other physicians learn more about helping patients?
Well, I guess to read articles, read the literature. There's a lot of literature on the Abernethy Malformation. If you just kind of go on PubMed and type in congenital portosystemic shunts or the Abernethy Malformation, you will get a lot of stuff popping up. And so there's a lot of information out there. We've written articles about it. As I said, we can always do a better job in writing and educating people. You don't really learn a lot about this in medical school. I don't think I ever heard about it until I saw a patient with it. And in fact, the first patients that I saw had associated liver disease that needed a transplant. And that's how I learned about it. And the Japanese had written about it as well, because patients with the Abernethy Malformation have very interesting adaptive mechanisms in their gut in terms of the bacteria they have, because one of the big manifestations of the Abernethy Malformation is high ammonias, and so high ammonias are produced in a way by the gut, and so the gut organisms. Anyways, I sort of digress, but yeah, you have to, I don't know, it's easy to say, write to me, email me, look me up.
Yeah.
I'll tell you all I can about it, which I can go on all day about it.
This video will hopefully help that.
Yeah, that's a great idea.
In what circumstances would you recommend a liver transplant for a type 1 patient? That's something that I keep reading in medical journals where they talk about doing these liver transplants. Is that something that you would recommend?
No, I do not recommend a liver transplant for the Abernethy Malformation. It's terrible that people are actually getting transplanted for the Abernethy Malformation. Many of the patients we get now are self-referred, or they're seeking a second opinion because they've been told they need a liver transplant somewhere else. In fact, the kid we did yesterday was told, and these people do not come from little centers, they come from big centers that have big transplant programs. But in our center, we try to think a little bit outside the box. So, replacing the liver seems to be almost a too easy a solution. I mean, just boom, do the liver transplant, rather than grow this portal vein. But even surgeons and physicians who work with the liver all day long may not be aware of this technique that we've used. And interestingly enough, the French have also developed in parallel with us to avoid liver transplants. So I would say that there might have been some patients in retrospect who came to us who might have been better off with a liver transplant, but I can't really say that, in all honesty, anybody would have been better off with a liver transplant. Certainly not the ones we've treated, and the ones who've been, who come to us for a second opinion, who were going to get a liver transplant in their home, wherever that was. So I would have to say that I have, in those 150 patients that I've seen with the Abernethy, there may have been one who would have been okay to get a liver transplant. But by the time they came to see me, their lungs were so bad that they couldn't get a liver transplant. So we tried to help them without a liver. And it's like everything, you don't have 100% success.
What is a liver nodule? How is it treated, and are they dangerous?
So a liver nodule is simply a spot on the liver, as it were, a little area of abnormal liver. Liver nodules can be all sizes. They can be very small, they can be huge. It's a very non-specific term. So a liver nodule is something that it's a descriptive term. that means that you've got a mass, an abnormal area of the liver that, if you were to biopsy it, would come back abnormal. So they can be anything from benign to malignant. They can be different, more precise diagnostic categories. So they by and of itself, they're not dangerous. But they can grow and they can change, and they can become cancerous. So in the long run, some of them can be dangerous.
You kind of already answered this part, but are there specific heart conditions that you would sometimes associate with an Abernethy malformation?
So we've like I said, 25% of patients have some form of heart disease, congenital heart disease. I think the commonest ones are probably, the common forms of heart disease, VSDs, like ventricular septal defects. But some of them have more complex, like tetralogies of Fallot. I remember one patient from Canada who had a univentricular heart, where heart surgeons had to basically need a heart transplant in order to fix them. So all kinds of spectrum, from very, very mild to something that is really complex and hard to treat.
Okay, would you say that's the same with breathing issues? Is it just a variety of
Breathing
different
issues?
types? Yeah, with the lungs?
No, the breathing issues are very different. The breathing issues are almost all reversible without with our operation, but nothing, you don't have to do anything to the lungs. The lungs are basically like an innocent bystander. They become abnormal because of the shunting. So not only do they exchange oxygen more poorly, but they can also develop this really high blood pressure in the lungs that ends up causing the heart to fail. And I think there comes a point where this might not be reversible anymore.
Okay. I'm seeing another question come through. Wouldn't the transplant be the only option after time when the liver, veins, and arteries clot up over time? So that's basically your only option is a transplant?
They don't clot up. It's kind of how can I say it? I think it's looking at the problem the wrong way. I think that our recommendations are to treat the Abernethy malformations as soon as they are diagnosed. Because I think what the person is referring to is that over time, the portal vein, as small as it might be, may atrophy away, may just completely kind of wither away. It doesn't really clot. But the shunt becomes so dominant that the portal vein inside the liver is unsalvageable. So perhaps that's true, but that's a theoretical situation. I have not encountered it yet. I have seen children, young adults, who respond very well to that treatment, and younger children who have a much more severe form of the Abernethy, in the sense that their portal veins are almost absent. So it's really, if we go back to that old classification, the ones with the congenital absence of the portal vein, or the ones with truly tiny little portal veins, they're the ones who are more likely to need a transplant than the other kind. But as I said before, it's the person who cannot be helped with the non-transplant option is very rare, and I've yet to see them. So if you give me somebody who's at a very early stage, we can usually cure them.
Okay, so I want to talk a little bit about the treatment options that you do for liver shunt. One of them is the gradual occlusion versus transplant. Just basically, what is an occlusion?
So, well, the term occlusion means that you block something, you stop it from flowing. So imagine, I like to think of, when I meet patients, I sometimes try to think of a metaphor or an analogy that makes them understand what's really happening. So the Abernethy Malformation is usually a very robust communication between the mesenteric venous system and the systemic venous system. It's like a super highway. So there's cars going down that highway at a very high speed. They're all going in the wrong direction. And what we've got to do is make them change direction. So what we do is we occlude it. It's like a roadblock. We just, boom, we stop the flow going down this highway and try to redirect it into a smaller country road that over time develops into a bigger and bigger road that can accommodate more and more traffic. So what we do in an occlusion, we do diagnostic occlusions, and those are radiological, whereby the portosystemic shunt is occluded temporarily with a balloon that's placed by a radiologist, and that enables us to see the true nature of the portal vein that's usually invisible otherwise. And then when surgically we occlude them usually in 1 or 2 stages, usually 2 stages, where we constrict it. We constrict the Abernethy Malformation to the point that it becomes harder for the blood to flow through this abnormal communication and easier for it to go through the actual portal vein. And then as that portal vein grows, we constrict it even more so that now the blood has to go through the portal vein. And many times that portal vein will respond dramatically by expanding. So that's what we mean by the occlusion, is just stop the flow of blood through this abnormal communication.
Are there any other standard guidelines or parameters that you use to determine when to treat or not to treat an Abernethy Malformation surgically?
As opposed to radiologically, or you mean?
Yeah.
Maybe that's.
Yeah.
Yeah, we do. There's criteria. So the ones that are mostly intrahepatic, that are inside the liver, are harder for the surgeon to get at without actually removing a part of the liver. Those are the ones that are best treated by a radiologist by occluding the malformation. And one has to realize that the problem with placing a radiological device is that those radiological devices are then impossible to remove. So that if you want to, you have to be very sure, the radiologist has to be very sure of the safety of what they're doing before they go ahead and actually do it. Whereas when we're in surgery, we can kind of experiment a little more because we can occlude it, non-occluded, they're reversible. So the intrahepatic ones are more likely to be well treated by a radiologist. The extrahepatic ones, it depends where they are. If they're these long kind of Abernethy malformations that sort of wander down into the pelvis, I think they're their own classification. They're often accompanied by a normal portal vein or a pretty good portal vein, so those are very easily amenable to radiological treatment. But the more common kinds are these large, short communications where it's very hard for radiologists to land an occlusive device, particularly an occlusive device that is partial and then can become complete. And those are the ones that are more easily treated by surgery.
Moving into the next question, kind of transitions into this a little bit. I was going to ask you what the alternatives to an occlusion would be, but that kind of brings us into what is a REC shunt procedure? Why would you need one?
Well, that's a different problem, right?
Okay.
So it's a different problem, totally different problem. Now, for the REC shunt, that means that you don't have a congenital portosystemic shunt. The shunts that one has are more adaptive because the portal vein, the theory is you're born with a normal portal vein, but somehow something happens that makes you lose that portal vein, such as an umbilical vein catheter, or premature babies are born, sometimes they have IVs that are started in the belly button, And those belly button IVs go straight to the liver into the portal vein, and sometimes the very presence of a catheter can damage the portal vein and lead to a clot, an actual clot forming, and then we can fix those with a rec shunt, which is actually a bypass. Those patients have portal veins inside the liver. They're not like the Abernethys whatsoever, but there is a rare circumstance, and we're kind of excited about it because, you know, that's what we do, where some patients with the Abernethy can be transformed into patients who have inefficient portal veins that then can be improved upon with a rec shunt. That's a very rare circumstance. So the two are related, often confused, but quite different.
Good. How long will a basic occlusion take, and what would be the steps in radiology?
So they don't take that long, an hour or two. Depends on what they're trying to achieve. You know, we've had patients who come to us from other centers who might have spent 12 hours under fluoroscopy trying to get some specific intervention done. But the diagnostic ones usually take half an hour to an hour.
Do they have certain steps that they do after diagnostics? If you could go back, I keep hearing about like a step 2 and a step 3. How does that?
For the radiological?
Yeah, for that part of it.
I'm not sure about that.
No.
Well, they, first of all, what you're talking about is a venogram, an occlusion venogram, I think,
Okay.
right? So I think with those, you basically have to insert a catheter, usually through the groin or through the neck, and then you they find a communication and just do a contrast study so you can see it really, really clearly. And I think the difficult part then, the second stage, is to position a balloon exactly where the communication exists and blow up that balloon, and so that you create that occlusion, that roadblock. And then what you do is you inject into the mesenteric venous system, and then the contrast has nowhere to go except through a portal vein if it's there. And so that's how you demonstrate the portal vein. And at the same time, they'll measure the pressures. So the blood pressure in the portal venous system is usually very low, 5 to 10 millimeters of mercury, because it's a low pressure system.
Mm-hmm.
Blood goes through the liver easily without much resistance. When you do an occlusion, that pressure shoots up, because I sort of use that analogy of the traffic again. Imagine if you create a roadblock on a highway, traffic just backs up, so that like you have a traffic jam, and that's analogous to having this high pressure system, and that's a dangerous situation. So they'll let the balloon down immediately and restore the abnormal circulation, but that's why, so having that venogram gives us not only a picture of the problem, but it gives us an idea of what the consequence of the problem is, and if you try to occlude it too quickly.
Okay. What if I don't have the occlusion? If someone's recommended that I have it and I don't do it?
The occlusion is a you mean like the treatment?
The treatment, or the
Yeah,
actual closure.
The actual closure?
Yeah.
Well, I think what happens is that, the consequences continue. Not everybody agrees that they have to be treated. I think some people think that there's still sort of some weird anatomical curiosity, just like having, I don't know, a funny nose or something, not particularly of any consequence. But I disagree with that. So I think if you don't have the operation, or you don't have the occlusion, then you risk some of those things that we talked about.
Okay, I'm seeing some questions coming through on risks of scar tissue adhesions. Is there anything that you could give us information on that?
Adhesions in the abdomen after an operation? Yeah, that's true. I mean, it's possible. It's any operation, even a small operation, can cause scar tissue to form.
At any age?
Yeah, scar tissue always forms.
Okay.
but it's very rarely bad. You can get a bowel obstruction, no question about it.
Moving on to post-surgery. Why do I need to be put on a blood thinner? And how long do I need to be put on a blood thinner?
So our experience has indicated to us, to me, that a blood thinner is A, essential, and B, should last for at least 6 months after the operation. And so if you go back to what my earlier remarks were, that when you do this blockage, you create a situation where the blood slows down, like in that traffic jam. It goes through a narrow channel, whereas all that blood used to go through a very wide channel at a very high speed. So when you slow blood down, it tends to clot. And if you form a clot in the veins that drain the abdomen, that drain the intestine, there's a problem, a real problem. So you jeopardize the health of the gut. And so we've had patients form clots in that mesenteric venous system, and but none of them have been severe enough to really jeopardize the health of the gut. We've tried to dissolve clots in a variety of ways. Injection of TPA, which is tissue plasminogen activator, manual extraction, not manual, but mechanical extraction of the clot radiologically. So the best way to treat them is to prevent them from ever happening, and that's why we treat them with heparin at first, which is intravenous anticoagulant, and then patients can go home, usually for 3 to 6 months. We tried 3 months. I mean, one patient came back with a clot that we had to then deal with. So we said, oh, maybe we should just go for 6 months. And so that's how the 6-month rule came about.
Okay, this question came from the UK. My son transplanted as an Abernethy patient and is expecting his first child, and we were wondering whether there is anything he should be aware of regarding the condition possibly being hereditary, and would screening scans detect the condition?
So this patient had a transplant, it sounds like.
Yeah.
Well, if they have a transplant, then they no longer have an Abernethy malformation, so there's nothing to worry about other than the normal post-transplant stuff, which, there's some things that they have to do. As far as the hereditary part of the question goes, I've never seen it run in a family. I don't know that anyone has. I don't know if it's ever been reported, but Abernethy malformations are reported often in an individual case-by-case reporting system. Like we might report on our 70 cases, but sometimes somebody will say, hey, I have twins who have an omphalocele, or twins who have this, or something that runs in the family that has a true genetic origin. But as far as I know, there is no genetic chromosomal predisposition to having the Abernethy.
I see another question coming in. Long term, should we be worried about medications harming the liver? For example, ADHD meds, Tylenol, ibuprofen.
So the answer to that is no. You don't have to be worried about it, except in taking things like Tylenol to an excess. So that the liver is not more sensitive to the Tylenol or alcohol. People are often worried about alcohol. Can I have a drink? Say, well, sure, you can have a drink, but you can't, drink to excess, or you shouldn't drink to excess. Ibuprofen has absolutely no effects on the liver.
All right. There are other questions, and yes, it looks like I did miss one of them. I don't believe. Oh, just the risk of being too young, like if their body doesn't have enough space. This is regarding scar tissue. And is there a higher risk of scar tissue adhesions? We answered that. Developmental delays is another one. What does research show about Abernethy kids and developmental delays? Do all the kids catch up from these developmental delays?
Good question. I think that we're actually doing a study right now. It's starting. It hasn't even started yet. We tried to enroll our first patient yesterday, but we were not able to, partly because the child didn't want to do it and he was 16. So you can't force somebody to do the test. But it would be nice to do it, because what we're trying to do, it's a very easy test. It takes about 45 minutes to have 60 minutes, and it's on an iPad. It's like a game. So it's like one of these like brain teasers, it's like a series of questions. I think many patients are diagnosed with attention deficit disorder, and I think it's just a manifestation of minimal hepatic encephalopathy. And so I think that the answer, we have a lot more experience with that condition with rec shunts, actually, with patients who have portal vein thrombosis. We know that that condition is reversible and that most patients have some minimal hepatic encephalopathy. And I would think that just from anecdotal experience with the patients with Abernethy's, I get actually emails or sometimes Facebook requests for, like, I can't sleep, or I can't go to university, or I can't do this, or I can't do that. And like, yeah, that's because you have the shunt. And if you get the shunt fixed, it'll probably get better.
Yeah.
So absolutely, it'll get better if it's fixed.
Here's another good question. Do you still say you have an Abernethy syndrome after you've been treated?
I don't know. I guess you always have the condition, right? Because but it's like, if you have I don't know, I used in orthopedic, if you have scoliosis and it's fixed, right? I mean, do you still have scoliosis? Probably not. I mean, you might still have a bit of a curvature, but I think the manifestations of the Abernethy are gone. You might still say you had it, or you have an anatomical situation that is not completely normal, but from a physiological standpoint, you should be normal.
Okay, good. All right, so this is just some newer methods of treatment since when Maddie had her surgery. But how have the techniques changed over the years that help you treat an Abernethy malformation? For example, today, the blood flow and the new technology found in the MRI machines.
Yeah. So I'm not sure what you're referring to about the new technology.
Yeah, what new things?
The diagnostic accuracy of radiological tests is becoming much better. There's more contrast agents, there's better machines that have better resolution, create better images so that we can understand them better. In our center especially, where radiologists have been seeing now the Abernethy Malformation for almost 20 years, we're very used to it. One of our radiologists has been very, very important, playing a key role in getting the diagnosis of flow through veins, the assessment of flows through veins, reach a much better form of accuracy. So for example, when you think of an MR scan, you think mostly of a picture that you look at, and you can see the picture, you can see what the characteristics of that picture are, but it's almost like a combination of MR and ultrasound, where you can now measure the flow of blood through a vessel. So let's say the portal vein, for example. Now we have the ability to measure the cardiac output, so the total amount of blood that the heart puts out in a minute, say, the number of times the heart beats in a minute, and the number of cc's of blood that the heart beats, that the heart puts out with every beat. So let's say it puts out, 20 mLs, 60 with each beat, and it beats 60 times a minute. So you know your cardiac output is going to be 1.2 liters per minute, which is kind of a normal cardiac output. So when we have an Abernethy now, we can measure the flow of blood after the correction. Before the correction, the vessels are really quite small, so that's it's still very hard to do. But we can now have a more functional assessment rather than simply a picture.
Someone just wrote in about that ADHD test. We were just talking about they wanted to download it on their iPad. Is there a possibility to get that test?
You have to talk to my research assistant. It's an NIH toolbox. I think it's not, I don't know if it's available to the public. I think you have to learn how to administer it, interpret it. We have a neuropsychologist who's working with us. I don't think it's something like one of those online IQ tests that you can take,
How about another question that came through? Are there any other hospitals experienced in treating Abernethy?
So, sure, there are. Like I said at the beginning of this session, we have a very, very similar group of people who are very interested in Abernethy Malformation in France, in Paris. There's a hospital in France, the Bicêtre Hospital in Paris, that have a very advanced surgical hepatobiliary unit. Physicians, surgeons, and radiologists who work together. And we are kind of like the Western Center, and they are, I don't know, I guess they're also in the West, but more east of us. There's not a lot of experience. I think Japan has written a fair amount about the Abernethy Malformation. So there's some Japanese centers, and there's a Japanese surgeon who's come up with a classification. I think those would be the three main centers. In the United States, we are by far the center that has the most experience with this condition.
What medication is commonly seen for treating high ammonia?
There's three kinds of medication in general. Two are antibiotics. So one, it's not used that much anymore, neomycin. So if you think about where the ammonia comes from, it doesn't, you don't breathe it in. You actually eat it in protein. So nitrogen in protein breaks down and forms ammonia in the gut by bacteria. So if you eliminate the bacteria by antibiotics, it's impossible to eliminate all the bacteria in the gut, because that's what our gut is. It's full of bacteria. It's called the microbiome. But if you change that microbiome and with the use of antibiotics, you will hopefully reduce the amount of ammonia that's absorbed. So there's neomycin. More recently, there's something called rifaximin, which is an antibiotic that's a non-absorbable antibiotic that kills bacteria in the gut. And then lactulose is another one that's taken. Lactulose is more of a laxative, so that it kind of makes you go a lot more often to the bathroom, so that the load of bacteria is reduced that way. Those are the three main drugs that are used for ammonia. But others are put in a low protein diet, which helps with the formation of ammonia. It's not, it's not great for kids who like to eat protein.
Hard. All right, we have heard that you travel the world to help kids with this condition. What is the farthest distance you have gone to help a patient with an Abernethy Malformation?
I don't know what's further, Brazil or Israel, but those are the two places I've actually done this operation in, other than Chicago.
Wow.
You need a lot of sophisticated equipment. So I've gone to like third world countries like Nepal to do other kinds of surgery, but you run into these, a lot of things that you wouldn't normally, like you come from Minnesota, right? So in Nepal, when I was there and I'd said to somebody, okay, so we've done this operation, now you gotta come back and see me next week. They're like, I can't, it's impossible. It takes me 3 weeks to get here by walking. So there are things that we don't think about. You need a fairly sophisticated medical center in order to do these operations.
Definitely. For people who are not ready to take the steps medically, what advice would you give them, and what should they have tested or watched for before they seek treatment?
Most of the people I see are children. I have seen young adults. Obviously, adults can decide for themselves what the risks are that they want to take. And maybe, for example, I have there's a nurse in her 40s who's thinking about should she have the operation, because she's functioned pretty well for 4 decades, and so she's kind of pondering what are the benefits, potential benefits, and maybe there's an adaptive mechanism that allows people to live into their 40s and 50s without having obvious symptoms of encephalopathy. She may have a very mild form of the malformation. But I think if you have a child with it, you think about the decades ahead. I would say that the very presence of the malformation, as a parent, you would want to be able to position your child in the best possible way to do anything, go to school, and never mind prevent liver cancer or prevent lung disease, just function normally. You would want, people do all, like for example, you talked about ADHD. I think from my perspective, more and more kids are diagnosed with ADHD and are put on medications for the ADHD. I mean, those drugs are amphetamines most of the time, so you're going to be taking amphetamines for the rest of your life. And as maybe a neuropsychologist would object to what I just said, but if you can take away the source of that neurocognitive deficit that's impairing you from thinking clearly, or impairing your memory, or impairing you from concentrating, then I think anybody would want that for their kid.
When the step 1 occlusion procedure doesn't work for a patient, what is the next step?
So that's a kind of I'm not sure what that person's getting at. Is that?
If they do the closure, and let's say that
some of the communications are too big to completely occlude, and those are the ones that really need the surgery the most, because from a surgical standpoint, we can do the occlusion more efficiently than with radiologically with a balloon. But the instruments that the radiologists have are also becoming more and more sophisticated and better. So it's very rare to have a malformation that is not amenable to at least a diagnostic occlusion. The therapeutic occlusions are very different, because those are more complex. They are easier to get right. In other words, occlude just enough to cause a diversion of blood to the portal vein, but not enough to cause that backup of blood that would jeopardize the health of your gut. That we can achieve, I think, more precisely using surgery at the moment.
I don't know if this applies then, because it says how long do you wait and watch, but what safeguards do you put into place to monitor side effects of high liver pressure, esophageal varices, gastric varices, low platelet count while you wait?
So those are we don't get those. So what that person is asking is, are we creating portal hypertension? So yes, we are creating portal hypertension, but temporarily, because what is going to happen, or what we hope will happen, is that the portal vein will expand and the pressure in that portal venous system will go back to normal. So with big spleens, low platelets, varices, that person is talking about symptomatic portal hypertension, which we do not produce when we do the Abernethy. We see those symptoms with the patients with portal vein thrombosis, and that's why with those patients need an operation. But with the ligations of the Abernethys, we try very hard not to create the conditions that cause portal hypertension.
Okay. Here's another question that some families have been asked when explaining the procedures that their child is receiving. Basically, why can't we just get the Rex shunt first instead of trying the step 1 occlusion surgery? But it's a different, like you already said.
Yeah, it's that I would need to have a diagram or something. I mean, that is actually, even when I give talks to our ICU fellows and residents, because they sometimes get the two things kind of mixed up. They know it's got something to do with the portal vein, but they're treating other conditions all day long. So they see more of this than almost anybody in the country in terms of our ICU doctors. So they're like seeing that all the time, and they're like wondering, what is this? So I give them talks, and one of the talks I give them is compare and contrast the Abernethy malformation with portal vein thrombosis. You cannot treat the Abernethy malformation with a REC shunt.
Okay, do you see a correlation between an Abernethy malformation and growth? There's a lot in this question. There's a paragraph. How does an Abernethy malformation impact growth, and what changes do you see following corrective surgery? And then also, what would you say to endocrinologists that want to place Abernethy malformation patients on growth hormones for idiopathic short stature, small for no reason? Do you want to see this one?
Small for no reason?
Yeah.
Oh, it's okay, I
Okay,
understand.
Okay.
No, it's a good question. Complicated. We have not studied growth in patients with the Abernethy malformation. We have studied it much more extensively in the patients who need REC shunts because they're more common. And so parents would often come to me and say, after the REC shunt, oh, my child is growing so much, I have to buy all new clothes, you know what's going on? And they're like, so we did an exhaustive study of the reasons for poor growth before a REC shunt. I think many of those same reasons might apply to the Abernethy malformation patients, but we haven't studied them. So I can't tell you that growth, you know, many of our kids who come and see us have actually normal growth. I mean, they're not small for size, or they don't have growth failure. So I don't know the answer to that question. But we do know that the liver is very important in the metabolism or the manifestation of growth hormone. So when growth hormone is secreted by the brain, it goes into the liver and it changes into other types of chemical that then affect growth. So I don't know how giving somebody extra growth hormone is going to help them grow if that growth hormone never makes it to the liver, because that's what happens, right? The growth hormone has to make it to the liver, and there it's metabolized to IGF-1 or IGF-2. I'm not an expert in growth hormones, but we have actually measured that in patients who before and after REC shunts, and we think there's a change. It would be interesting to do the same studies in patients with the Abernethy malformation. But, you know, it'd be nice to do those actually.
Do you know offhand how many cases are found in adults and how their treatment may differ?
The answer to that is we do not know the incidence of the Abernethy malformation in the general population. And I think in general, the earlier it's treated, the better, the more responsive it is.
What are the long-term prognosis for patients who have the shunt repair? Are there any drugs or foods to avoid after the repair or for the future?
I think we restore people to normal. That's my goal. And so there are no restrictions. Not everybody has optimal results. There are some patients who do end up having some kind of niggling problems later on, but those are the exceptions rather than the rules. Most of the patients end up having a normal life, normal food, and normal everything. Without a transplant, I should add.
Here's the last question. How many physicians have you personally trained on an Abernethy?
I would say that most surgeons that have trained under me go on to become general pediatric surgeons. They don't treat this kind of stuff. A lot of the people who do the kind of work I do are transplant surgeons, therefore the great interest in transplanting patients with Abernethys. There's probably one or two people, I think, who are competent enough to do the steps necessary to do this kind of operation.